Welcome back to Sleep Medicine and Physical Therapy. This is part 3, Physiotherapeutic Management of Sleep Disturbances, with the topic of insomnia, an overview. I'm HKMU Physio Chris. Let's go. Insomnia is defined as a subjective perception of persistent difficulty with sleep initiation, duration, consolidation, and quality that occurs despite adequate opportunity and circumstances for sleep, and results in some form of daytime impairment. Diurnal repercussions may include drowsiness, fatigue, reduced cognitive performance, memory impairment, irritability, and mood disturbances. The International Classification of Sleep Disorders classifies insomnia into 3 categories. 1. Chronic insomnia disorder, characterized by chronic sleep onset and/or sleep maintenance complaints with associated daytime impairment. 2. Short-term insomnia disorder, characterized by sleep-wake difficulties that fail to meet the minimal frequency and duration criteria of chronic insomnia disorder and associated with clinically significant sleep dissatisfaction or waking impairment. 3. Other insomnia disorders assigned to those rare cases that fail to meet the criteria for short-term insomnia disorder but present sufficient symptoms of insomnia that need clinical consideration. Insomnia is a multifactorial disorder with social, environmental, and psychological involvement factors. In addition, gender has a strong effect on the prevalence of insomnia, with women having insomnia more frequently than men at a ratio of 4:1. This difference becomes even greater after the age of 45, reaching a ratio of 7:1. The prevalence of insomnia varies between 10 to 30%, sometimes reaching 60% in some countries. It is important to emphasize that the complaint of dissatisfaction with sleep is not characterized as a diagnosis of insomnia. Insomnia can be a symptom, an isolated one, a secondary one, due to a medication, an event, or a stressor factor. Therefore, insomnia complaints may not characterize a diagnosis of insomnia. From the perspective of behavioral science, the multi-dimensional model of chronic insomnia, 3P, helps explain how acute insomnia becomes chronic, establishes the basis for evaluating insomnia in individual patients, and focuses on predisposing, precipitating, and perpetuating factors in the long-term evolution of insomnia. Predisposing factors, which are generally not modifiable, include genetic and personality characteristics, for example, being worrisome, family history of unsatisfactory sleep, leading to physiological and cognitive hyperexcitation. Precipitating factors that trigger insomnia are typically stressful events such as problems related to health, family, work or school, and anxiety. Perpetuating factors are the poorly adaptive behaviors, thoughts, and coping strategies that allow insomnia to continue after the original triggers are solved, such as daytime naps, staying for a long time in bed without sleeping and ruminating, early bedtime, or long time in bed after waking up. The least quantifiable perpetuators include dysfunctional beliefs, expectations, and attributions about sleep, as well as an intense desire to solve the sleep problem. Maladaptive strategies such as increasing time in bed awake result in the conditioning of the bed to waking. The same happens if one works or eats in bed or bedroom. Susceptible individuals are prone to focus excessively and in an exaggerated fashion on potential daytime consequences of insomnia. The result of this focus is progressive, autonomic, and emotional arousal that triggers a myriad of problems which worsen the disturbance. As for the pathophysiology of insomnia, it's not totally clear, but it involves genetic, environmental, behavioral, and physiological factors that culminate in cerebral hyperexcitation, causing this on and symptom system to be unbalanced, leaving the patient in a state of hypervigilance. Evidence of hyperexcitation in insomnia include high metabolic rate during sleep and wakefulness, elevation of cortisol and adrenocorticotropic hormone during the initial sleep period, heart rate variability, and high frequency of EEG activity during sleep. Functional imaging studies demonstrate minor differences between wakefulness and sleep in regional brain metabolism in individuals with insomnia disorder compared to people without insomnia. Contents covered. We've covered what is insomnia, the etiology of insomnia, and the pathophysiology of insomnia. This is Insomnia, an overview. My name is Chris, physiotherapy student, signing out.